Okay, so let's move on to chronic kidney disease. So a condition that occurs over years typically, and there's gradual elevation of BUN and creatinine, and a declining glomerular filtration rate of the kidneys. So the kidneys are basically like filters, and their filtration ability is declining over time. Okay? So it's a very progressive condition that's irreversible because the underlying problem with chronic kidney disease is loss of nephrons. Okay, so there's been injuries to the kidney, say for example by chronic hypertension or by having diabetes, and over time nephrons have been lost. So the 1 million nephrons that you have in each kidney have declined in numbers. Okay, and as the decline continues, the worse the chronic kidney disease becomes, and the declining filtration rate of the kidney worsens, right? So, and of course, the body and the system is accumulating more waste and, of course, more symptoms and signs. Okay, so it's typically a gradual process from a disease state, and the remaining nephrons that are still able to function have some ability to hypertrophy, to enlarge, and to try and compensate for the loss of nephrons that's occurring. Okay, so on this list here, I would definitely think hypertension and diabetes are the most common cause of chronic kidney disease. But any of these can cause it, right? So a chronic glomerulonephritis. We spoke about recurrent pyelonephritis leading to chronic pyelonephritis. That's going to lead to chronic kidney disease. Chronic obstructions from BPH in a male can cause chronic kidney disease. So really any kind of ongoing disease state that's continually injuring the nephrons can lead to gradual deterioration in kidney function, which we call chronic kidney disease. So in chronic kidney disease, we can stage it through 5 different stages. Okay, so from mild to end stage renal disease. So stage 1 is a GFR that's greater than 90 milliliters per minute, and we think that the kidney is at risk for injury. Okay, so that's still a very well functioning kidney with a GFR of greater than 90. Stage 2 so these are really just numbered stages according to the glomerular filtration rate, right? So stage 2, 60 to 89. Okay, mild disease. Maybe the chronic hypertension needs addressing to try and slow down the chronic kidney disease progression. Maybe the diabetes needs better control. So often you can intervene to try and slow down the progression of chronic kidney disease. Stage 3, GFR of 30 to 59. That's definitely moderate to severe disease. Stage 4, 15 to 29. So that's not a lot of filtration anymore. So 15 to 29 milliliters per minute. That's a small amount of filtration per minute. So really below 30 is where typically we need to adjust drug doses, right? Because the kidneys are filtering so slowly because they've been weakened that drugs typically accumulate in the body. So when we start to see a GFR below 30, medication doses need to be adjusted downwards typically. Stage 5 is less than 15 in terms of GFR, and that is really end-stage renal disease. And many of these patients need to now go for dialysis or be prepared for dialysis, right? There's two types of dialysis. There's hemodialysis, where we attach a filtration unit through your bloodstream. And then there's peritoneal dialysis, where we put fluid into the abdominal cavity to remove toxins from the blood. Okay, or finally, transplant. So some patients can be candidates for a renal transplant in order to survive. So really at stage 5, you're looking at dialysis or a renal transplant. And as you go through these stages from 1 to 5, the amount of waste that's building up in the blood is increasing. The kidney function tests such as BUN and creatinine are increasing. The ability for the kidney to concentrate is decreasing. So it's a gradual process, right? And as you get to the higher stages, such as stage 4 or 5, you're at risk for all kinds of conditions and diseases, right? Because when you have kidney disease, it affects so many other organs. It impairs wound healing. You're immunosuppressed because of all the waste that's in your blood. You're at risk for hyperkalemia, which can be deadly. You're at risk for acidosis because you're not able to clear the acid in your bloodstream. So many conditions start to appear, and often you feel weak, you feel sick, so just chronic malaise we call it. So it's a gradual process. So let's look at these dietary limitations in chronic kidney disease. So the first one is protein. Okay, so eating protein should be limited in chronic kidney disease because protein is broken down to amino acids in the liver. And the liver decides what to do with the amino acids, right? It can make new proteins, which it often does. It recycles amino acids. Or it can break down the amino acids through the urea cycle to produce urea that can then be excreted by the kidneys, right? So if we're consuming large amounts of protein, we're potentially making more and more blood urea nitrogen, and that's going to build up in the blood as waste. Okay, so protein limiting diets is important in chronic kidney disease. Potassium, well, the kidneys have a difficult time excreting potassium as they get weaker and weaker. So definitely being careful with the amount of potassium that a patient is taking when they have chronic kidney disease is very important. Sodium, well, sodium makes you drink, right? So sodium makes you thirsty. What happens when you consume very salty meals every day is that you drink more, and that increases your plasma volume. Your kidneys may not be strong enough to volume regulate anymore, and you can become volume overloaded and get into trouble with peripheral edema, potentially pulmonary edema. So dietary sodium needs to be regulated as well. What about phosphorus? So where does most of the phosphorus come from in your body? Well, it comes from your bones, right? So when your kidneys are getting weaker and weaker and weaker, what aren't they producing that could interfere with phosphorus or calcium? Well, it reduces the production of active vitamin D, right? So inactive vitamin D is produced in the skin. It becomes activated in the kidney, and then vitamin D allows absorption of calcium in the gastrointestinal tract. Okay? So when you don't have active vitamin D, you're not absorbing calcium in the gastrointestinal tract. Okay? What does that have to do with phosphorus? Well, if you're not absorbing calcium from the gastrointestinal tract, then your calcium is low in your serum. Your parathyroid hormone is now being secreted by your parathyroid glands to stimulate the bones to break down and release more calcium into the bloodstream to raise the serum calcium. Okay? But in the process of releasing calcium from the bone, phosphorus is released because the bone holds calcium as calcium phosphate. So now, not only is the parathyroid hormone trying to elevate your calcium level, which is great, because the active vitamin D is lacking, so you're hypocalcemic. So it's doing the parathyroid hormone is doing everything it can to raise calcium levels, but at the same time, it's raising phosphate levels. So because phosphate levels are often elevated in chronic kidney disease, we limit it in the diet. Okay? And by the way, calcium supplementation is needed in chronic kidney disease because they're often hypocalcemic. So you're going to see many patients that have chronic kidney disease on active vitamin D, which is called calcitriol, because they're not making it in their kidneys anymore. And they're also taking a calcium supplement. Okay? So basically they have high phosphate because the parathyroid hormone has been trying to get the calcium levels up in the bloodstream. But in the process of doing that, it's released a lot of phosphate from the bones as well. What about magnesium? Well, magnesium can come in the diet. It's common in many laxatives that we suggest patients with chronic kidney disease should avoid. So we don't give milk of magnesia or other magnesium-containing laxatives to patients with chronic kidney disease because the kidney has difficulty excreting magnesium. So it's going to build up in the bloodstream. Okay, so hopefully most of these make sense about why we need to avoid them in the diet in the setting of chronic kidney disease. Okay, so let's just remind ourselves here of the vital functions of the kidneys. I know we've looked at the slide a couple hours ago, but I think with the information that's been provided, you'll probably have an even stronger insight of how important the kidneys are and how these functions are lost with chronic kidney disease. Okay, so regulation of blood pressure and blood volume. That's all about the ability for the kidneys to filter the blood, so your GFR, and it's all about being able to control blood pressure through not only filtering, but also reabsorbing with using different hormones, such as ADH, such as aldosterone, such as BNP. All these hormones are interacting to regulate the overall blood volume, okay? Which is then going to control what the blood pressure is. Acid-base balance, okay? Remember, the kidney has the ability to excrete H+, which is acid, and it has the ability to produce bicarbonate. So that ability diminishes with chronic kidney disease. Regulating electrolytes, well, as the kidneys become more and more diseased and weakened, the ability to regulate sodium and potassium and magnesium and phosphate declines, right? It makes it much more difficult to be regulating all these electrolytes as the kidneys decline in function. Removing waste, BUN, creatinine, any waste products that are coming to the kidneys to be eliminated are being eliminated at a much slower rate when the GFR is declining, or what we calculate as the GFR, the creatinine clearance. Okay. The ability to stimulate RBC production with erythropoietin, well, that's declining too, because the kidneys aren't making erythropoietin any longer, or it's significantly declined in production. And then regulating vitamin D and calcium, we just spoke about that, the lack of the kidneys to activate vitamin D and to absorb calcium from the gastrointestinal tract results in hypocalcemia. That results in the parathyroid gland being secreted by the parathyroid hormone being secreted by the parathyroid gland to try and raise calcium levels. And in the process of the parathyroid hormone releasing calcium from the bones also causes release of phosphate, and patients with chronic kidney disease develop hyperphosphatemia, high phosphate levels in the blood. Okay, so let's go on to the next slide. That was just a little reminder, but now since we're talking about chronic kidney disease, I thought it'd be a good time just to remind you. Okay, so what potential changes in levels of electrolytes and hormones and blood cells can we expect with chronic kidney disease? Well, sodium can potentially increase, right? Potassium can increase since it's not being excreted. Chloride can increase. Hydrogen atoms can increase, which can lead to a metabolic acidosis because the kidneys can't excrete the hydrogen ions and they're not making bicarbonate as well. Magnesium can increase, again, because the glomerular filtration rate has declined. Phosphate increases because parathyroid hormone is constantly trying to break down the bone to release calcium to try and elevate that low calcium level. BUN and creatinine are both blood markers of kidney function. They're definitely going to be increased with chronic kidney disease. And parathyroid hormone. And we spoke about the reasons why parathyroid hormone is almost invariably going to be increased, because you have hypocalcemia. In chronic kidney disease, the parathyroid hormone is being secreted by the parathyroids to try and increase that calcium in the serum. What's decreased? Well, okay, there's calcium, right? So calcium is decreased from the inability of the kidneys to produce active vitamin D. The gastrointestinal tract isn't absorbing calcium, which results in hypocalcemia, which then leads to increased parathyroid secretion. Okay, so a lot of these are connected. Erythropoietin, when it's not made in the kidney, will not stimulate the bone marrow to produce red blood cells, and that will result in anemia. right? Vitamin D production is, or active vitamin D is decreased in the blood, okay? Which results in lack of calcium absorption from the gastrointestinal tract. And of course, red blood cells are decreased because the erythropoietin is decreased from the kidney. So the kidney performs a lot of functions, and as the kidneys decline in function, a lot of electrolytes, some hormones, vitamins decline. So try and put this all together. I hope this voiceover helps you, but it'll start to make sense as you are just concentrating on each one. So combine calcium, vitamin D, and PTH together, okay? And the phosphate, actually. That's all happening because there's low calcium in the serum, because there's low active vitamin D, since the kidneys can't produce it anymore. Erythropoietin and the red blood cells connect together. BU and creatinine connect together. Those are waste products. The inability to excrete electrolytes, so they build up in the bloodstream. Okay, that makes sense. The hydrogen ions are not being excreted. That can lead to a metabolic acidosis. Okay, so at the top we have chronic kidney disease, and we just spoke about the first line of effects there at the top there. So sodium and water balance is affected, increased potassium, the difficulty to eliminate waste. So nitrogenous wastes is really just referring to BUN, right? So nitrogen is a breakdown product from amino acids, and it becomes urea, and you can't excrete it. Erythropoietin production declines. Acid-base balance is altered because you can't get rid of the H+. The inability to activate vitamin D, and finally the inability to eliminate phosphate. So let's look at the effects now. So in terms of sodium and water balance, well, that's going to lead to hypertension. So chronic kidney disease leads to hypertension. Well, that's not a great thing, because now hypertension damages arteries all over the body, and now these patients are at risk for heart disease. It's also damaging the kidneys, by the way, as well. So the hypertension that's caused by the kidneys is now damaging the kidneys even further. Okay. The sodium and water balance leads to increased intravascular volume, and patients can go into congestive heart failure because of that. Okay, so sodium and water balance, think of hypertension and increased plasma volume that can lead to heart failure and pulmonary edema, right? And actually edema all over your body too, so peripheral edema in your legs. The inability to excrete potassium, hyperkalemia, which can be deadly because of cardiac arrhythmias. The inability to excrete BUN and creatinine, well, that's a pretty important one. So when you have waste products floating through the blood, it makes your coagulation system very poor. Your coagulation system doesn't clot as quickly, so you tend to have bleeding problems. So often these patients will have bruises on their skin. Their platelets, even though they're normal in numbers, they don't work very well in dirty blood. So there's coagulopathies, right? Poor clotting from platelets and the coagulation system. What else can happen with uremia, all this waste product in the blood? Well, impaired immune function from all this waste, skin disorders because you have poor tissue healing, gastrointestinal symptoms, lack of appetite, nausea, because of this waste that's going through your bloodstream. Neurological symptoms, again, because of the waste. Your brain isn't being perfused with clean blood. Okay, so patients can end up being confused, lethargic, fatigued. Okay, because of just the poor condition of their blood, and as well sexual dysfunction. Again, because of these excessive waste products that are affecting the sexual organs and the blood that's going to the sexual organs. Erythropoietin production is declined. Well, that leads to anemia, right? Decreased levels of red blood cells in the bloodstream, or decreased levels of hemoglobin. Acid-base balance can lead to acidosis. There is there's lack of activation of vitamin D that we've spoken about, which leads to hypocalcemia because it can't absorb it from the gastrointestinal tract. And parathyroid hormone is activated because of the low calcium, so you get hyperparathyroidism, excessive PTH in the bloodstream. That stimulates the bone to break down, to release calcium, to try and elevate this low calcium in the serum, but at the same time, it leads to high phosphate levels, right? So, which is a problem because now the phosphate can't be excreted. So, patients with chronic kidney disease get a lot of bone issues called osteodystrophies. The bone is being broken down to try and maintain the low serum calcium. So PTH is always being stimulated and going to the bone and continually trying to break down the bone to release calcium. So they get a lot of bone disorders. So it's pretty amazing what happens when your kidneys decline in function. Okay, so this will be very similar to the slide above in terms of information. So if you want to skip over this slide, that's fine. Or otherwise, listen to the information again. Since the more times you hear something, the better it sticks. So these are all symptoms and signs of chronic kidney disease and what we can call a uremic state, right? So elevated BUN and creatinine, when they're very elevated in severe chronic kidney disease, we would call the patient uremic. Okay, so starting at the top, that encephalopathy we get from all the waste products, the poor concentration, the lethargy, the fatigue, confusion, and even potentially coma. The uremic fetor, they have a particular smell on their breath, okay, from the high uremia in their saliva, okay? So they have a particular smell to their breath. The hyperparathyroidism we spoke about, why the parathyroid glands are secreting so much PTH, it's due to the lack of calcium being absorbed from the gastrointestinal tract because the kidneys are unable to make active vitamin D. The hypertension, due to the inability for the kidneys to regulate plasma volume and also declining GFR, that's increasing plasma volume, leading to hypertension. Heart failure, due to hypertension and also hypervolemia, right? Elevated levels of volume in the bloodstream. So both of those conditions, the hypertension, because now the heart has to pump against a higher pressure to get blood out of the left ventricle into the systolic circulation, and also there's an overall increased plasma volume. Infertility and erectile dysfunction comes directly from the waste products in the bloodstream, affecting the sperm and also the ability to have an erection. Renal osteodystrophy has to do with the lack of active vitamin D production in the kidney, which then leads to, again, low calcium in the blood, hypocalcemia, which then leads to increased levels of PTH, which are continually stimulating bone breakdown, trying to elevate that calcium level, and in the process, breaking down the bones, causing renal osteodystrophy, and also elevating blood phosphate levels. Waste products in the blood can lead to a peripheral neuropathy, so pins and needles, and lack of sensation in fingers and toes, right? That sounds similar to diabetes, because diabetes can do that too, but uremia can do the same thing. Peripheral edema, due to the kidney's inability to filter the blood, there is an expansion of the plasma volume. Definitely elevated BUN and creatinine, since they're not being excreted in the kidneys. Anemia due to reduced erythropoietin, which can lead to weakness, fatigue, dizziness, because the brain's not getting enough oxygen. If you're low on hemoglobin, you look pale. Electrolyte imbalances, so the big ones, hyperkalemia and metabolic acidosis, right? Because the kidney is unable to properly excrete potassium and H+ ions. Thrombocytopenia, well, you can get thrombocytopenia, which is low platelets, but what's even more common is a normal platelet count, but the platelets don't stick together very well because of all the waste products floating in the bloodstream. So patients with uremia are much more prone to nosebleeds, bruising of the skin, gum bleeding, okay, from abnormal platelets. All right, so that was just more of a review of the slide above, but I hope it still helps.